Dr. Karnatanos, thank you so much for joining us here on MD Newsline Podcast. Can you please introduce yourself to our audience?
Thank you very much. My name is Theo Karnatanos. I am an assistant professor of medical oncology at Johns Hopkins University, Sidney Kimmel Cancer Center in Baltimore. And I'm a laboratory-based physician scientist focusing on the understanding of the role of inflammatory signaling in high-risk myelodysplastic syndrome and acute myeloid leukemia, and the development of novel targeted therapies that can inhibit these pathways.
Mm-hmm. And just to start off, can you please provide us just a brief overview of the central hypothesis behind your study on how inflammatory pathways can contribute to treatment resistance in myeloid neoplasms?
So it has been shown by us and other groups that high-risk myelodysplastic syndrome and acute myeloid leukemia, such as monocytic leukemias and TP53 mutated disease, tend to have upregulation of a number of inflammatory pathways. Those are linked to resistance to a number of agents, including chemotherapy and particularly venetoclax. Our hypothesis focuses mainly on the some interaction between those inflammatory pathways and some growth signaling, but also alteration of the apoptotic priming in the mitochondria that is a key mechanism of cell death related to venetoclax. Obviously, we need further studies, both in vitro and in vivo, to validate these mechanisms.
And what initially drew your research focus towards inflammation-mediated mechanisms rather than purely genetic or epigenetic drivers of resistance?
That's a great question. I initially was interested in sex-related differences in myeloid neoplasm. So men tend to do worse than female. So I was interested in looking into that. And interestingly, androgen receptor, which, as we know, is activated more in males than females, regulates a number of inflammatory chemokine receptors. And one of them, called CCRL2, attracted my attention because it was particularly overexpressed in high-risk MDS and secondary AML, meaning AML arising from MDS. And I studied CCRL2 a little more in the lab. We performed gene editing, knock it down in a number of models, and found that basically this chemokine receptor mainly regulates inflammatory pathways, and that's how I linked my research with inflammatory pathways.
Mm-hmm. And how does this work fit into the broader picture of disease evolution and resistance observed across myeloid malignancies such as MDS or AML?
That's also a great question. We start understanding how inflammatory pathways are linked to disease expansion, evolution, and treatment resistance. It looks like there are two main hypotheses that mutated cells, mutated hematopoietic stem cells, derive some survival advantage in the setting of a very inflammatory microenvironment. So that's one hypothesis, that simply having mutations allows the cells to grow more in the inflammatory microenvironment. The other hypothesis is that this inflammatory signaling is linked to growth, activation of those malignant cells, and acquisition of more mutations can promote further these pathways. I think the truth is somewhere in the middle. There are both mechanisms involved, but I think understanding better how we can modulate inflammatory pathways at different stages of disease progression will be a key to understand better the downstream impact.
Very interesting. I want to talk to you a little bit about some mechanistic insights about inflammation and resistance specifically. Can you just briefly walk us through the specific inflammatory signaling pathways most implicated in promoting therapy resistance?
Yes, so one pathway that really we study in the lab and has been highlighted by another group as well related to venetoclax resistance is interferon gamma signaling. So interferon gamma response inside malignant cells starts from the interferon gamma receptor, then causes autophosphorylation of JAK2, which leads to accumulation of molecules called STAT1, STAT3, and STAT5 that then they're getting phosphorylated and moved to the nucleus and regulate the expression of a number of downstream targets. Some of them are interferon-related genes, IRFs or ISG, and also a number of receptors, eventually cells, proteins that are expressed in the cell surface, such as ICAM1. So it looks like the majority of those genes, their expression is linked to venetoclax resistance. And that's what we are really interested in understanding. One thing that has attracted our attention, this is what we published recently, is that deletion of P53, which is a protein that is critical for the repair of DNA damage, cell cycle arrest, even apoptosis as a result of DNA damage stimuli. And the loss of P53 really makes acute myeloid leukemia and myelodysplastic syndrome really, really hard to treat because simply the cells cannot die. They are very resistant to most of the apoptotic mechanisms or other mechanisms of cell death that we use. We utilize giving venetoclax or chemotherapy. Then the loss of P53 we saw that causes a direct upregulation of interferon gamma signalings, like without any implication of the bone or marrow microenvironment. So it seems that there is a cell intrinsic phenomenon linked to P53. Obviously, we need to further confirm that in a number of models and understand it, but I think this could be an important contributor to venetoclax resistance that we see in these malignancies.
Interesting. What are some of the key post-translational modifications that appear to regulate these inflammatory cascades, and how do they influence cell survival under therapeutic pressure?
So we know that phosphorylation and ubiquitination are all key important post-transcriptional modification for a number of those genes. We have studied a little more phosphorylation of STAT1 in the context of activation of molecules such as JAK1 and JAK2, and all this obviously creates a much more complex concept because we cannot rely on RNA data and transcriptional data or single cell RNA transcriptomics. We need to understand more proteomics and understand also the regulation at the protein level of some of these pathways.
hmm Um, how do inflammatory cytokines or metabolic reprogramming of bone marrow, for example, bone marrow microenvironments, contribute to resistance in malignant myeloid clones?
That is a great question for sure. We know that during treatment with most of the therapies, including chemotherapy and venetoclax, there are critical alterations in the bone marrow microenvironment. More recently, we have heard about, even in this ASH, about basically adipose tissue changes in the bone marrow microenvironment, especially with FLT3 inhibitors. But also we know about fibroblasts and venetoclax and chemotherapy. So I'm pretty sure that those alterations change the cytokines and the interaction between the bone marrow microenvironment and the malignant cells. We do know that upregulation, increased secretion of IL-1B and TNF-alpha in the bone marrow microenvironment is associated with chemotherapy resistance and most recently venetoclax resistance.
Mm. Is there evidence that inflammation-induced epigenetic remodeling creates a permissive state of resistance subclones to emerge or persist?
Yeah, of course. I mean, epigenetic alterations are key for in a number of those myeloid neoplasms, especially those that have specific mutations in genes such as DNMT3A, TET2. And in that setting, we know that epigenetic changes are also important. With regards to inflammatory signaling, it's a good question. I'm not aware of specific, impact of epigenetic alterations, but I'm pretty sure that that's the key.
To your knowledge, are there any specific particular myeloid cell subsets, such as monocytic progenitors, that are especially prone to inflammation-associated resistance dynamics?
For sure. We know that monocytic leukemias, M4, particularly M5 leukemias, appear to be to show significant activation of inflammatory signaling, including interferon gamma and TNF alpha. Most of these signals of activation are linked to exogenous signaling coming from natural killer cells, dendritic cells, and other cells in the bone marrow microenvironment. But definitely, I would think that monocytic leukemias are particularly inflammatory as a result of activation of these pathways. Yes, they are prone to be.
I want to talk a little bit about translational and therapeutic implications. So, from a translational perspective, how might modulation of inflammatory pathways enhance therapeutic efficacy? For example, in patients receiving, hypomethylating agents or targeted therapies.
So, developing this to a more translational project and moving it to the clinic is obviously particularly challenging. In AML, we know that we haven't made amazing progress on the survival of these patients for many, many years, and improving azacitidine venetoclax outcomes has not been particularly easy. But I would say there are a couple of ways. One is targeting these inflammatory pathways it appears to be promising, at least in preclinical models. Obviously, clinical trials need to be done. We know that IRAK1 and IRAK4 inhibitors, for example, appear to be quite effective when combined with venetoclax in preclinical models, or when we have developed those drugs that target both IRAK1 and 4 and FLT3. So one way is to target these pathways. The second way would be to target pathways that molecules that activate downstream signaling, such as JAK-STAT pathway. So targeting JAK2 with ruxolitinib has not been particularly effective, but we haven't seen so far any even preclinical studies looking at STAT inhibitors in that setting. So that, I think, would be very interesting too. The last approach is what we have been doing in my lab for some time. We have tried to develop antibody drug conjugates, where we use as antibodies that target a number of downstream genes that are regulated by interferon gamma signaling, including CCRL2 and ICAM1, particularly in TP53 mutated MDS AML, where we don't have available antibody drug conjugates. So just targeting the molecules that we know that are overexpressed in these leukemias.
Mhm. And even outside of the drugs or combinations that you're thinking about in your lab, are there any candidates or combinations that are showing promise in preclinical models?
If you're referring to specifically inflammatory
Yes.
signaling, I don't know any others other than the IRAK inhibitors. I mean, IL-1B inhibition in earlier stages, we have tested for clonal hematopoiesis, but not in advanced myeloid neoplasms. Obviously, ruxolitinib is a treatment that is, in my opinion, non-specific, and it's more an anti-inflammatory agent in myelofibrosis and polycythemia vera. Now, these are the main, I think, combinations that have moved a little more than just preclinical models.
Hmm. And then, are there any specific inflammatory biomarkers such as CRP, cytokine profiles, or phosphosignature markers that may predict which patients are at a greater risk of treatment failure?
I think this is a hard question because, AML, particularly, and MDS are in general very inflammatory diseases. So it would require a very high number of patients, big cohorts to study that. Definitely, I don't think CRP or ESR, like non-specific markers, would not be, I think, something that I would look into. But I think, for example, IL-8 has already been identified as a possible marker of bad outcomes for patients with MDS or AML, but not in the context of treatment. So that would be a very interesting thing to look into.
And just kind of thinking forward on that, in that line of thinking, how might these biomarkers be incorporated into clinical decision making or even trial design going forward? Any thoughts?
I think I would start with clinical trials that are ongoing, including those inhibitors like IRAK1, IRAK4, and other inhibitors of nuclear factor kappa B. There, I think they are studying some of those cytokines. The other source of data for this is myelofibrosis, because ruxolitinib is a very good agent to target inflammation, and I know that they are looking at cytokines there. So I would start there, look at specific responses and correlate with cytokines, and then move it to perhaps MDS and AML.
Hmm. Let's talk a little bit about disease microenvironments and systems. The bone marrow microenvironment is increasingly recognized as a driver of resistance. For example, could you describe how the crosstalk between malignant and immune cells shape therapeutic response?
Absolutely. I mean, one mechanism that we forget sometimes is that in the bone marrow microenvironment, the number of cells are metabolizing even the drugs. So we should not forget that the concentration of the drugs that finally reach the malignant cells is much lower than what we have tested, for example, in vitro and even in vivo models. So one simple mechanism is the metabolism of those drugs, and our colleagues at Johns Hopkins have published extensively about this. The other is as you mentioned earlier, cytokines that are secreted from specific subsets of malignant cells, such as fibroblasts, adipose tissue cells, chondrocytes, and osteoblasts can mediate resistance, so cytokines. And finally, we know interaction, integrins and other molecules that are critical for cells, for this cell-cell interaction. They are also associated with resistance.
Mhm. Are stromal or mesenchymal elements also altered by inflammation in ways that feed back into the myeloid cell survival?
For sure. I mean, we don't know exactly where this, like, which cells are the sources of this inflammatory cytokines and which ones are the kind of the cells that receive the signal. But we know, for example, that endothelial cells change significantly, and as a result of inflammatory signaling from other cells, pericytes or even glial cells that are in the bone marrow microenvironment. So definitely, we see that inflammation can alter completely the bone marrow microenvironment. And now with the single cell RNA sequencing and even spatial transcriptomics that we are getting, we see that even more, that both during progression of a number of myeloid diseases, but also during treatment, we see significant alterations. So that is key. Now, we don't know exactly what is coming from the leukemia or the myeloid neoplasms and what's coming from the microenvironment, and this needs more advanced models to study.
Mhm. How do you see computational or single cell approaches advancing our understanding of the inflammatory networks at play in myeloid neoplasms?
I think that it's basically we cannot do it without the computational analysis. I mean, this is a huge amount of data, especially the single cell approaches and spatial transcriptomics that we do require computational biology to understand cell populations and even understand simply which cells change, which cells secrete factors, and how does that affect specifically the leukemia cells. If we base our understanding in the traditional flow cytometry and cell sorting, it's just simply impossible. So I would say computational biology is definitely required.
Beyond transcriptional activation, which post translational modifications, such as phosphorylation or methylation, for instance, seem most pivotal in mediating inflammatory resistance mechanisms?
I think phosphorylation is obviously the first, because the activation of inflammatory signaling requires specific protein phosphorylation, such as I mentioned earlier, JAK1, JAK2, STAT1, STAT3, STAT5. They require phosphorylation, autophosphorylation, for the alteration of their activity and transcriptional modification eventually by STAT, for example, which is a key for inflammatory signaling. Now, obviously, the protein levels and activity is affected by other post-translational modifications, such as ubiquitination, which has been found to change significantly. One other thing that's very interesting is how to link spliceosome changes in the splicing of the RNA with activation of inflammatory signaling. We know that altered splicing of specific genes, which is caused by alterations of the spliceosome machinery, which are seen very much in MDS, for example. I remind you, U2AF1, ZRSF2 or SRSF2, and other spliceosome molecules are altered in MDS and AML, and that leads to alternate splicing, which affects significantly a number of components of nuclear factor kappa B and TNF alpha, for example.
Have you observed specific modifications or signaling proteins or metabolic regulators that could serve as actionable nodes for drug targeting?
And you are referring to both inflammatory pathways and metabolic
Yes.
alterations. So more recently, we know that metabolic alterations are critical in a number of. I mean, we obviously know that AML with IDH1, IDH2 mutations is critical. There are critical changes in metabolic signaling. However, we know that TP53 mutated MDS AML also has characteristic metabolic abnormalities. Not targetable at this point, but I would hope that we will understand better how to target these pathways and then can introduce a number of new drugs for this. So metabolic alterations for sure. Inflammatory signaling, I mentioned most of the ones that are promising, such as nuclear factor kappa B, I think TNF alpha signaling, but also JAK-STAT. And I will insist that potentially STAT inhibition has not been studied as well as it should be in leukemias.
Do post translational events, these post translational events, differ between primary resistance and acquired resistance after therapy exposure?
So post-translational modifications that are different between acquired resistance and primary refractory disease. Yes, we know that primary refractory disease and acquired resistance sometimes are different. We would expect post-translational modifications to be a little more prominent in acquired resistance in most of the cases, but we do see some some of those changes even in primary refractory disease. I think the main factor that alters those post-translational modifications is the initial mutations or the acquired mutations. So we shouldn't forget that all these events are associated with specific somatic mutations in most of the time, and they differ very much between different subgroups of leukemias.
Mhm. Wonderful. Let's talk a little bit about clinical outlooks and future directions. What are the biggest challenges in translating these mechanistic insights into real world clinical strategies for MDS and AML?
So I think the real difficulty here is to try to basically make azacitidine venetoclax better than it is. I think that that's really challenging because is a treatment regimen that works quite well, but and most of the patients respond quite well. So most of the patients will achieve complete remission. The problem is the relapse, the development of relapse, and then incorporating appropriate treatment in that setting. I think we are moving towards more triplets in at least acute myeloid leukemia and even high-risk myelodysplastic syndrome. And there, I don't see many players being able to improve azacitidine venetoclax alone. So for new agents that come, I think the key is to find the right time point to add the specific agent, potentially sequentially, to improve the outcomes. The other big challenge is that this is a very a variable disease. Like you can see some of these leukemias that have excellent responses and some others that we know that are going to become resistant. For example, the disease that I am focusing on, TP53 mutated MDS AML, we know that nothing of the things we have tried over the last decade have worked. So there, we need to find even something that works better than nothing.
Mhm. Interesting. Are there any ongoing clinical trials that specifically address inflammation blockade or microenvironmental reprogramming in resistant myeloid diseases?
So, disease resistant, I'm not entirely sure, but we know that IRAK1 and IRAK4 inhibitors are being tested with venetoclax in, I think, high risk myelodysplastic syndrome and acute myeloid leukemia. Yes.
How might patient stratification evolve as we integrate inflammatory pathway data and post translational profiles into clinical workflows?
I don't think we are doing that right now. I
Yeah.
think we are far from doing that because I think we need more work to highlight that inflammatory signaling is important. But again, I think there are specific subsets that I would focus on. For example, monocytic leukemias, I would look more carefully on the refractory diseases, the refractory samples, and see if inflammatory signaling is really changed. And the other, obviously, subgroup that there's plenty of room for work on this is TP53 mutated MDS AML. There, I think we can do much better on understanding how inflammatory signaling changes through treatment. Sometimes we have to incorporate bone marrow transplantation there, so see if relapses post BMT are associated with high inflammatory signaling.
Mhm. And we've kind of gotten into this a little bit, but outside of what you've mentioned, just looking ahead, what do you see as the next key experimental questions or technological advancements that are needed to overcome inflammatory driven resistance?
I think the future is obviously in spatial transcriptomics and single cell multiomics to understand what are the source of this inflammatory signaling, because I don't think we understand it very well. Is it indeed the leukemia cells, or basically the mutated hematopoietic cells that they start the cascade, or is something that starts from abnormal bone marrow microenvironment? And again, I think that there could be more than one answers. It could be that the mutated cells start the inflammatory cascade, but I'm pretty sure that alterations of the bone marrow microenvironment should be described at the more depth.
Wonderful. Well, this has been an amazing conversation.
Thank you.
Thank you so much for joining us on MD Newsline
Thank you.
podcast.
Thank you very much.